Are you saying something first, Ashley? I assume.
I was going to, if you guys are ready.
Perfect. Yeah, go for it.
Awesome. It is recording. Okay. Hi, everybody. Welcome to Provincial Rounds. So today we have kind of a different presentation, which we're really excited about. It's an infectious disease Ask Me Anything with our infectious disease pharmacists, Danielle in Saskatoon, and then Kristin and Melissa in Regina. So before I pass things over to them, just a couple housekeeping things. If everyone could put your name, location, and number of attendees logged into in the chat box, we can try and keep attendance. That would be great. Remember to mute yourselves. I'll try and keep an eye on things, but try and mute yourselves so that we can just hear the presenters. And then at the end, there will be a link posted to the evaluation. If you could please fill it out so we can hear your feedback, especially for this new format, that would be great. And we're recording this presentation and it'll be available on My Learning within a week or two. So I think that's all that I have to say. And now I will hand it over to our presenters.
All right, excellent. We have a lot to get through in 1 hour. Ashley has already introduced us, so I won't do that. As she said, this is an Ask Us Anything session, so thank you guys for submitting your questions ahead of time. All right, let me make sure I can advance the slides here. There we go. So before getting into the questions, take a moment and a breath to acknowledge that we're gathering across the province today on treaties 2, 4, 5, 6, 8, and 10 territories. This land acknowledgement is one small step in the process of reconciliation. For me, it's always a time as well to pause and reflect on the painful history of colonization in this province and the effect on Indigenous peoples. And as healthcare providers, we have a role to play in healing this past. All right, so objectives for our time together today. So we are going to answer the questions that you guys submitted via the survey. When we took a look at all of the responses, there was kind of 3 main themes that came out. So each of us are going to tackle one of them. The first one being interpretation of cultures. So I'm going to tackle that one. Then I'm going to pass things over to Danielle. She'll talk about MICs and breakpoints. What are they? Do I care about them? And if I care, how do I use them? And then Mel's going to take over and she's going to talk about all things infectious diseases resources. What are our favorite ones? Which ones do we use when? And possibly some other handy tools as well. And then we hope that there's going to be some time for live question and answer. So if we didn't get to your particular question that you asked or something else has come up in the meantime, this will be the time to ask. We will all benefit from that kind of discussion. So please don't be shy. I want to acknowledge as well that there was kind of a 4th theme that emerged in the responses to the survey, and that was around how do I implement antimicrobial stewardship at my site? How do I get prescribers to care about this? And we didn't feel it was really possible to answer that in a meaningful way in the time that we had. Antimicrobial stewardship interventions should usually be tailored to your specific site, the resources you have, the problems that you face. So if you want to talk about this question more specifically, please reach out to one of us and we would be more than happy to support in whatever way we can. All right, so first we're going to talk about cultures. There were a lot of different questions submitted, and it's not possible in the next 10 minutes for me to take you from A to Z and all the important things you have to consider when interpreting a culture. So I'm going to touch on just a few important things from our perspective where we often see people maybe misinterpret, and maybe touch on a few specific questions and go more specifically into blood cultures. Okay, so culture and sensitivity reports are a critical tool for us in medicine and for treating infections for a whole variety of reasons, but the most obvious to us is, helps us to choose our targeted therapy to treat infections. And a mistake we often see people make is really just taking them at face value. There needs to be some interpretation that goes into these results that you're getting, okay? So for me, this is the foundational bit of all of it. If I've learned anything over the last 4 years working with ID and then having, all these learners come through, this is really the foundation, is understanding the microbiology, knowing what the bugs do, where you find them, is really the base for all of it. So you have to understand the bugs in order to determine the role that they're playing in an infection or possibly not playing in an infection, okay? and to consider the complications or the metastatic infections that they could cause that you might need to search for if you find them, say, in a blood culture. Okay, so number one here, determining the role that they're playing or not in an infection is understanding, where do these organisms normally live? Where do they usually colonize? Where do I expect to find them? And then what kind of infections do they cause? So if you grow out a specific bug, say in a urine culture, an E. coli, that makes sense that I would find it there. But it doesn't make sense, for example, that I would find salmonella in a urine culture. So if that comes out, I probably need to be looking a little bit deeper into what's going on. So that's actually a perfect example. We had a couple months ago here in Regina, a patient who presented having had recurrent, what they called salmonella UTIs over the past few months. He just continued to receive course after course of antibiotics. But what it actually was a giant mycotic aneurysm that almost burst. And so this should have been a red flag, right? Salmonella growing in the urine is not a usual place we would find it. So that should have been a flag when we saw that come out, and then further searching, ordering blood cultures, knowing that salmonella can cause things like endocarditis or mycotic aneurysm, right? So that's just an example to illustrate the importance of understanding the micro, and that being the foundation of really kind of leveling up your infectious disease clinical game when it comes to interpreting cultures. So I'll also walk through these couple cultures that I put on the slide here. Again, salmonella, I don't know why I'm picking on that bug specifically, but these are cultures taken from the same patient. So the top one is from a nephrostomy tube, the bottom one from a blood culture. So I'm just going to tell you exactly what my thought process would be if I saw these two cultures together, okay? So my first thought is, okay, I see that salmonella has grown out in both of these cultures. I'm absolutely going to take that seriously. Salmonella can be part of our normal flora, but it doesn't contaminate blood cultures. It wouldn't really contaminate a nephrostomy tube culture. So for sure, I'm taking salmonella seriously, and then maybe investigating other possible harms that salmonella could do. But when you look at that nephrostomy tube culture, you also have Candida that grew out and VRE as well. So what do we do with those? Does our therapy need to target those bugs or not? So my thought process is, okay, Candida is everywhere. It's colonized our bodies all over the place. It's in the environment. So if these nephrostomy tubes have been in for any length of time, this is probably just colonization. Okay, and then a similar thought process for VRE. We find that in the GI tract, we find it in the urinary tract. So this could also just be a colonizer or even a contaminant. So if this patient isn't super sick, they don't have a ton of risk factors to become really sick, then probably my initial therapy is just going to target salmonella, and I'm not going to worry about those other bugs unless the patient doesn't get better. Okay. All right, so a couple other culture examples. These were specific ones that people had asked questions about. What do we do when we find yeast in the sputum and in the urine? Because this happens all the time, right? And people very often unnecessarily receive antifungals to treat this. So again, yeast is everywhere. So we expect that it's going to colonize many parts of the body. And so often that's all that this represents is colonization. It's not something that we need to be treating with antifungals, especially in urinary catheters that have been in for any amount of time. For sure, they're going to be colonized. And then growing in the sputum, I mean, Candida pneumonia is not really a clinical entity that we worry about. It's not really an infection that we ever see. And so when you see that grow out in the sputum, that represents colonization. Of course, people with specific risk factors who are super immunocompromised, who are critically ill, this could maybe point to a more disseminated infection. But for the most part, it's just colonization, and we don't need to be treating it. The other specific type of swab we were asked about was superficial wound swabs. What is their utility? How do I interpret them? So I see people in the room smiling, and that's because our skin is full of bacteria. So we expect when we swab it that something is going to grow out. So for sure, superficial skin swabs really have very little clinical utility. For a wound swab, there might be, but you have to expect that something is going to grow out, right? So our skin is colonized, wounds will become colonized, and so we expect that we're going to find bacteria there. I wouldn't recommend that we're routinely doing Superficial wound swabs, deep wound swabs are much more useful, especially if we're properly debriding that wound first and then going in and taking a deep culture. So if anybody has more specific questions on that, you can feel free to put those in the chat or ask us after. All right, blood cultures. Let's get into these in a little bit more detail. So a question came up, why do we collect multiple sets? Do we have to collect multiple sets of blood cultures? And the answer is yes, we should collect multiple sets. And this is because it increases the sensitivity. So we're more likely to find something if we do multiple sets. If somebody is bacteremic, it's not like this perfect stream of microbes just flowing through your blood. It could be little bits that are being sent off. And so if you only do one set, you might miss it. So if you do multiple sets, you're more likely to find bacteria if there is bacteria there. And then it increases the specificity as well. If blood cultures are contaminated and you take multiple sets, it can help you to determine if it's truly contamination or not, if they don't grow out from all bottles, depending on what the bug is. If the person has any kind of central line whatsoever, please, please, please make sure that a set of blood cultures are drawn from that central line. Okay, so lines can become infected very easily. They can either be the source of a bacteremia or they can become secondarily infected. So drawing a set from that central line plus the periphery can help us determine if the line is involved with the infection. So the time to positivity is kind of the marker that we're looking for there. If it grows out much more quickly from a central line, like multiple hours more quickly, then likely the line is involved in the infection somehow, and we need to consider if it has to come out or not, okay? Which depends on what the bug is, patient factors, those kinds of things. Some bugs you absolutely want to take the line out. Some you can get away with, maybe not. Okay. Other important considerations for blood cultures. There was a question around which bugs should we treat as contaminants and which ones should we not? So there are some common ones that can contaminate blood cultures, right? Bugs that grow on your skin. The most usual one being coag staph of some kind. So if that just grows out in one set, people don't have other risk factors for a serious coag staph infection, then probably we can be comfortable with considering that a contaminant. But there's some bugs that we should never treat as contaminants. So the most important one being Staph aureus. Okay, Staph aureus can grow on your skin. So theoretically, it could contaminate a blood culture, but we should never treat it as a contaminant because it's very virulent, really high rates of morbidity, mortality with Staph aureus bacteremia. So we always treat it as if it's an infection. Gram negatives usually don't grow on your skin. So most often we wouldn't consider those to be contaminants either. Next question was, actually, no, this wasn't a question. This was an important point that we wanted to bring up. So this is a common thing that we see people doing. We get a lot of questions. So example, someone will call me and say, this patient is growing a strep anginosus or some kind of viridans group strep in their blood. How long should I treat it for? So as pharmacists, we're really good at seeing problem, solving problem, moving on to next problem. But there's a little bit more thought or nuance that should ideally go into this kind of assessment. So bacteria don't just spontaneously, start growing in your blood. They have come from somewhere. And in order to figure out how to properly manage that infection, you have to know what the source of it is. So this affects if surgical management is needed or how long you treat it as well, which is the big thing that we're looking at as pharmacists, right? So if you grow viridans group strep in your blood, and you have the foundational micro knowledge that I was talking about, you would ask yourself, okay, viridans group strep, it usually causes endocarditis, it grows in the GI tract, or we would find it there, we would find it in the mouth, and it likes to cause abscesses as well. So those are the things that I'm going to go searching for to find the source of that infection, okay? And then we manage it according to what the source is. Then we also have to think about, once that bacteria gets into the blood, what could it possibly do once it's there? So like Staph aureus, as I talked about before, maybe Staph aureus came from your skin. You had some kind of cellulitis, developed bacteremia, but now that it's there, it can wreak a lot of havoc and cause things like endocarditis, bone and joint infections. So we need to specifically go looking for those kinds of things for that particular bug. Another question was around repeating blood cultures. When do we need to do it? Do we need to do it? There isn't really a one size fits all answer to this question. For specific bugs, we should always repeat. So of course, Staph aureus is one of those bugs. We need to make sure that we sterilize the blood cultures, because if we don't sterilize blood cultures, we need to be considering, did we find the source of this infection? Did we control it properly? So for gram positives, we usually recommend that we should repeat blood cultures and make sure they clear, but for sure for Staph aureus. Gram negatives, it's a little less unclear. Some evidence says that patients have better outcomes if you do, but that's more often when you don't know perfectly what the source of the infection is. So then repeating blood cultures helps to show you if you found the source and controlled it or not. So if it's a pretty straightforward kind of infection, like an E. coli bacteremia, the patient had presented with classic UTI symptoms, they respond quickly to antibiotics, it's probably not necessary to repeat. But if you aren't sure what the source of that infection is, then absolutely repeat blood cultures to help you determine what's going on. So repeat always for Staph aureus, most gram positives, maybe for gram negatives. All right, another question for my section was around how do I choose an antibiotic regimen when multiple bugs grow out in culture and their sensitivities don't line up? So I can't choose one antibiotic that I know is going to kill all of the bugs that are in the culture. So just because an antibiotic isn't reported out in the sensitivity report doesn't mean it doesn't cover that bacteria. So the lab selectively reports these things. So it's usually a collaboration between microbiology and antimicrobial stewardship to decide which bugs or which antibiotics are reported out for which bugs, because we're trying to steer you towards the ones we want you to choose. Okay, so there could be a lot of other antibiotics that would also cover that bacteria that you might be able to use to choose one regimen that's going to cover all those different bugs. And in order to figure that out, you need to consult your resources. So Mel's going to talk about some of those things. You should also make friends with your local microbiologist. They can help a lot in this regard. And us as well. You can always call us. We're happy to have that conversation with you. So as I said, the best thing to do, go to your resources, call us. Ideally, you're choosing the regimen that has the narrowest spectrum, and it might be that you need to use more than one antibiotic to cover all of the bugs that grow out if they're all truly causing infection and not just contaminants or colonizers. All right, so for my section, to summarize things here that felt like a whirlwind, cultures are a critical tool to help us in choosing antibiotics, managing infections, but we need to interpret them rather than having implicit trust in what they might be telling us. So this is kind of my approach. When I think of interpreting a culture, these are the questions that I would ask myself. Number one, is this a good sample? Where did it come from? How reliable is it? How likely is it to be contaminated? So a sterile versus non-sterile site, some are more reliable than others. Number two, does it make sense to find this bug in this place? Should it be here? And does it cause this kind of infection? If it doesn't normally, then we're probably missing something. You need to look further. Call someone you trust, call an expert, we can help with that. And so as part of that question, we're determining, is this colonization, contamination, or actually a true infection, okay? Number three, does this organism usually cause this type of infection? So like I had just said, if it doesn't, then we might be missing something. For blood cultures, what is the source of this bacteremia? Have we properly controlled it? And how long do I treat that bacteremia based on what the source of the infection is? And number five, what is this organism capable of doing? So now that I find it in the blood as an example, what could it do? Could it cause endocarditis? Could it spread to this part of the body or that part of the body that we now need to go looking to make sure that that hasn't happened? Danielle, anything that you would add, or Mel?
No, I think you nailed it.
All right, so I will pass things over to Danielle.
All right, hello all. So a number of questions came in around MIC and how to interpret the MIC and the breakpoints and how do I use them clinically. So I am going to take the next 10 minutes and chat with you guys about that. Okay, so first off, I'm going to throw up on the slide here a culture and sensitivity report. So as you can see, this is a patient who the source is a blood culture and they're growing Pseudomonas aeruginosa. On the left-hand side here, you'll see you have all your antimicrobials. And then the second column is your MIC, which is a numerical value. And then the third column beside is the interpretation of that MIC value. So let's dig into this a little bit more. Okay, so what is the MIC then? So the MIC, I mean, I think all of you guys probably know this, is the minimum inhibitory concentration. So essentially, this is the lowest concentration of an antimicrobial that inhibits visible growth of an organism at 24 hours. So there's this visual depiction here that I threw up here showing test tubes. We now mostly do this via automated methods, but I thought I would show this because it's a good visual depiction of what the MIC actually is. So basically a known quantity of bacteria is placed in test tubes and there's varying concentrations of antibiotics. So you can see here on the left, we've got a low concentration of antibiotic, 0.25 microgram per mil, and then essentially a doubling to higher concentrations. So the MIC, that numerical value, is the lowest concentration that inhibits visible growth at 24 hours. So in this case, the MIC would be 4 micrograms per mil. It's important to note though that this is essentially measuring in vitro activity, right? So this is in a test tube. It doesn't consider any other patient factors. It doesn't consider body compartments or anything like that. So from there, what happens is essentially the CLSI, or the Clinical Laboratory Standards Institute, basically establishes breakpoints to say which numerical MIC value is an organism susceptible or resistant to a certain antibiotic. So that then brings us to our interpretation column, which is a letter, either S or R. And let's now delve into that for a second here. So this is pretty straightforward, but it's important to think about what this actually means. So essentially S, as we know, is susceptible. This implies that an isolate of that organism is going to be inhibited by usually achievable serum concentrations of an antibiotic when the normal dose is used. Okay, so you will likely result in clinical efficacy. I is intermediate. This implies that the isolate may have a lower response rate than susceptible. So you may be more likely to have clinical failure, but it's not necessarily resistant. So you would use caution in using that antibiotic if it reported out as intermediate. R, that's obvious, it's resistant. So you are unlikely to inhibit the growth of an organism at the usual achievable concentrations using normal dosing regimens. NS is non-susceptible. You'll see this for some newer antibiotics, and that's just because there isn't enough data to establish exact breakpoints on what's resistant for that particular antibiotic. So I would consider, like if you see NS, I would consider it as resistant, but it's just that there isn't enough data to specifically say resistant. And then SDD is susceptible dose dependent. So this means that you are, it implies that the isolate is likely to be inhibited, but you need higher doses than normal to inhibit that growth, okay? So the two examples that you will most commonly come across for this, and I wanted to highlight these, is Candida glabrata and fluconazole. So it will either be reported as SDD or resistant, okay? And if it's reported as SDD, then you need to use a higher dose. And you can find that in any, dosing reference, lexicon, etc., first line, okay? VRE and daptomycin is another one. So that's vancomycin resistant enterococcus. So it will either be reported as SDD or resistant, and you need to use higher doses of daptomycin if you need to treat that vancomycin resistant enterococcus. So for example, we would normally use in the realm of, 6 to 10 milligram per kilo normally, say for an MRSA infection. For VRE, you're probably more looking at 10 to 12 milligrams per kilo. Okay, and again, you'll find that in any dosing reference. Okay, so if there's anything that you're going to take away from my portion of the presentation, it is this. MICs are unique to each bug drug combo. You cannot compare, you cannot look at a culture and sensitivity report and say that this MIC is lower, so it must be better. That is just not true because MIC is unique to each bug drug combo. So looking back at this example again, you can't say that ciprofloxacin has the lowest MIC, so it must be better than ceftazidime. No, they are all susceptible. So any of them may be appropriate. The best antibiotic is going to be, considering the clinical picture of your patient. So what body compartment is that infection in, and where do I need to get that to? What adverse effects are associated with that antibiotic? Is there organ dysfunction? Can I use oral versus IV? All those sorts of things, okay? So I get many questions, and I see many slip-ups in this among pharmacists all the way up to physicians. You cannot compare MICs between antibiotics to determine which is the best, okay? Okay, so basically, when you're looking at that MIC value, 9 times out of 10, that numerical value you don't need to look at. It honestly causes a lot of confusion, and lots of micro labs don't report it out in other places in the country. We do here. So I guess now your question is, okay, well, what about the other 10% of the time? When do I actually care about that MIC value? Okay, so there's basically 2 main situations I could think of where there's value in looking at that numerical value. So the first one is Staphylococcus species and vancomycin, and then the second is Viridans group's strep infective endocarditis and penicillin. So let's go into the first one. Okay, so vancomycin and Staphylococcus. So we're going to throw up a culture and sensitivity report. So this is unique to Saskatoon. This is how ours report out. It might be different in your location. But basically, this is a blood culture. This came from a patient who had staph epi prosthetic valve endocarditis, I believe. And you'll see there's a comment here that vancomycin MIC is greater than 1 microgram per mil, might be associated with increased risk of treatment failure. And you can see down here the MIC is 2. Okay, and this is staph epi, so a coagulase negative staph. So let's delve into that and figure out where that comes from. Okay, so vancomycin, where this comes from is literature on vancomycin and MRSA. So basically, there's well-supported literature to show that a vancomycin MIC of 2 micrograms per mil or greater for MRSA is associated with clinical failure and increased risk of mortality. So the bottom line here is that, the IDSA guidelines for MRSA infections recommend that you would use an alternative agent if you had an MIC of greater than 1, okay? So then what about coagulase negative staph? This question comes up a lot. So essentially when I dug into the literature, there isn't a ton. It's essentially hypothesized that vancomycin MICs of 2 or greater for coagulase negative staph may lead to worse outcomes similar to MRSA. The evidence is conflicting and really it's quite minimal. So the bottom line here is that really, we care less about the cons MICs than we do MRSA. MRSA, we definitely care about. You could consider changing to an alternative agent for coagulase negative staph infection if they're not improving, if your blood cultures aren't clearing, you're having trouble with source control, that sort of thing. But if you have a patient on week 4 of vancomycin, you've seen this MIC creep, they still have negative cultures, they're afebrile, they're doing clinically great, I would leave it. I wouldn't jump to switch to daptoceftobiprole, which is commonly what is done, okay? All right, so our next situation where we actually care about that numerical value of the MIC is in Viridans group strep endocarditis and your penicillin MIC. So Viridans group strep, that's like strep mitis, strep salivarius, strep anginosus, they commonly cause endocarditis. We know that. And they can actually exhibit variable penicillin resistance. And your endocarditis treatment is guided by that numerical MIC value, okay? So up on the screen here, you can see the categories. I'm not going to delve too deep into them. You can look them up. You're not going to memorize them. That's not the point of this. And essentially you will, what I want you to remember is that anytime you have a patient who is a Viridans group strep bacteremia and you're considering endocarditis, or you know that there's endocarditis, remember that we care about the MIC and that you need to look it up because the treatment will be guided by that. So you can look at first line. We've got guidelines there, as well as your American Heart Association or European endocarditis guidelines. So I'm just going to show an example of how your therapy would change based on the MIC. So here's a patient, 76-year-old female with strep gordoni, that's a Viridans group strep, native valve, tricuspid valve endocarditis. You can see here that the penicillin MIC is 0.38, and that would fall into that intermediate resistant category, or relatively resistant, and it's ceftriaxone susceptible. So let's see what the guidelines would say then based on that MIC. So if your MIC was totally susceptible, less than 0.12, you could do Pen-G or ceftriaxone for 4 weeks. But if your MIC is greater than that, you could still do Pen-G, but you would have to add on gentamicin for the first 2 weeks, or you could do ceftriaxone if the ceftriaxone MIC was less than 0.5, or you could do vancomycin for 4 weeks. And then that will change too, whether this was a native valve, but if you've got prosthetic valve, that would obviously change things as well. So this is just an example of how your therapy is guided by that MIC, and it's important to make note of that. Okay, so the bottom line here is we definitely care about the Viridans group strep, penicillin MICs when we're treating endocarditis. And really that's the majority of the time, like those are the two main situations where I would actually look at the numerical value of the MIC. And that sums up my section. If we want to move on to Mel's.
Great, thanks, Danielle. Okay, so I'm covering resources. We got a couple questions on what are our favorite resources, what's our process of going through resources. So I feel like I got the less exciting topic of all of the questions, but that's okay. So I'm going to go through some of the resources that we like to use, what my process looks like. A lot of these I'm sure you guys are very familiar with, but hopefully I can show you something new that you can use in your clinical practice. Okay, so by far, I think our favorite #1 resource is the Sanford Guide. There is a subscription required for this. It's not very expensive. It's about $40 a year, but we use this for absolutely everything. If I am looking up an infection, if I want to know what my empiric antibiotics are, if I want to know what dose to use, if I want to know what bugs to target, I'll refer to Sanford's. I particularly like it for the renal dose adjustment section. I think it gives nice, clear guidance on what to do in renal dysfunction. So I'll definitely use that as a starting point. And then if it doesn't if it has a couple options to do, then I'll, do my double check or my triple check, and I'll look to things like LexiComp or First Line or Bugs and Drugs or other resources. But Sanford's really good guidance around dose adjustments. Obviously, they have their activity spectra chart, which is really helpful. So if I have a bacteria and I want to know just general susceptibility patterns of that bacteria, I'll refer to this chart because it is quite comprehensive. And I'll look at that maybe before I look at my local antibiogram, which might not be as comprehensive. And then also there's a section under tables and tools that has some unique guidance on specific dosing recommendations. So they have a section on ECMO drug dosing adjustments. So for the critical care pharmacists out there, this is very relevant to you. There's a section on obesity dosing adjustment, intraperitoneal dosing. So lots of good sections in there that I encourage you to take a look at. First Line, really good resource, lots of good guidelines. I wouldn't say that I typically use it on a regular basis, mainly because we're the ones who are either creating the content or updating the content, so we know the content. But I would say they are really good guidelines. When we're creating the content or when we're updating the guidelines, we're obviously looking at national, international guidelines, but then we're trying to very much put a local lens or a stewardship perspective on our recommendations that we're putting forward, because usually these national, international guidelines are going to be a little bit more aggressive, a little bit more broad spectrum. So when we're looking at this and interpreting it within our clinical context, we're being a little bit more stewardship friendly, more mindful of what those recommendations are. So definitely use First Line. Other highlights are obviously we have all of our local antibiogram information on First Line, super important for knowing your local resistance patterns. There's the penicillin allergy delabeling tool, great tool for reassessing penicillin allergies, helps you risk stratify your patients. And lets you know how to manage them moving forward. And then there's a nice cross-reactivity section. Bugs and Drugs, another good resource that we like, highlights there. I'd like the cross-reactivity chart within Bugs and Drugs. They have a nice section on guide to gram stain interpretation. I like using that for choosing my empiric antibiotics. And then also the CSF penetration of antimicrobials is a nice little tool as well. Up to date, love Up to Date. There is a subscription required for this. It is expensive. I think it's like a couple $100 a year. But I will use Up to Date if I want to know more about kind of the pathophysiology of the infection, if I want to know more about the microbiology, if I want to know more about the diagnostic process of the infection, what imaging is required, that sort of thing, I'll refer to Up to Date. It's very comprehensive, so it nicely summarizes the evidence as well and gives you guidance on empiric antibiotics and dosing as well. So Up to Date is really good. And then a nice alternative to that, if you don't want to pay for the subscription, is Dynamed. Dynamed is another good comprehensive guide as well. Our X-Files is very much community focused, but the one thing I'll highlight here that I often still use is the nice little antibiotics and pregnancy lactation chart. I find that very nice, succinct, and very helpful. Lexicomp I've kind of grayed out because I'll be honest, I don't typically use it on a regular basis in my daily practice. When I'm looking at dosing recommendations, I'll either use Sanford's, I'll look at Up to Date. When I use Lexi, it's usually to do a double check if I'm, doing a recommendation on dose adjusting and renal dysfunction, or even obesity, for example. I'll use Lexi as that double check to see what they recommend. Or if I want more information on side effects of an antibiotic, I'll look at Lexicomp for that. If I want more information around the pharmacokinetics of the drug, I'll refer to Lexi for that. Or if I need to remind myself what the mechanism of action is, I will go to Lexi for that. But it's not something that I use necessarily on a daily basis. Guidelines. So IDSC guidelines are kind of the holy grail of guidelines for infectious disease. We use these on a regular basis. Wiki guidelines are they're newer guidelines. There's only about a handful of these guidelines that are developed, but they are created with the recommendations, I think, are just more practical, and they're trying to, I guess, really incorporate real world settings, give more practical, reasonable recommendations. So I'd encourage you to check those out. I think they have one on osteomyelitis. I think there's another one on endocarditis. So they have some really good practical recommendations that you can apply into your practice. The STVBI Canadian guidelines are another good resource, obviously, to use. For websites, our SHA Antimicrobial Stewardship Program website, obviously, we think it's a really good website. We're open to feedback as well. We post things like presentations on there. We've got lots of posters on there that you can feel free to use. We have useful documents that we'll post on there that we've gotten our residents or our students to work on. So there's documents on ceftriaxone dosing, utility of MRSA swabs, pediatric dosing recommendations for amoxicillin or clavulin. Lots of good tools on that website. AMI Canada is another website that Kristin really likes. So if you work in long-term care, they are very much known for their symptom-free P Let It Be campaign. And they have a lot of good tools within there, a lot of good information. So you can check that out. Sci-Hub is another website that a medical resident introduced me to, and it can get you free access to journal articles. So if I'm doing a quick Google search and there's a journal article that I want to read, but it's restricted access, before I reach out to the library to see if they can send me the full article, I'll throw the article into Sci-Hub, and sometimes I'll get a free article back. It's not super comprehensive, so I still sometimes have to go through the library, but I'll often try Sci-Hub first. And then just to stay up to date with what's going on in the ID world, you can create an account through Evidence Alerts or QXMD Read, and select, the areas that you're interested in, and they'll email you updates, new journal articles that get published or new guidelines, that sort of thing. And then if you're into podcasts, Breakpoints is a really good podcast. They have lots of good infectious disease topics on there, a lot of good episodes. So encourage you to check that out. And then just some kind of tidbit resources. So there are some questions around HIV, Hep C resources. Shout out to Jackie Myers. She's our HIV, Hep C kind of guru pharmacist here in Regina. So this is her comprehensive list of all of her favorite resources. I'm not going to go through all of them, but we'll be posting this presentation, so you guys can go back and check out all of those links. But these are all of her favorite go-to guides whenever she has an HIV Hep C patient. Syphilis, we see a lot of syphilis. I think that we have a fantastic algorithm that I refer to on a regular basis. I think when we have a patient with syphilis, serology can be very difficult to interpret. So this algorithm really nicely lays out how to interpret that serology, and it's not super easy to find. So I've included the link here. Once again, you guys can go back to the presentation and maybe save this link on your favorites tab, because it's really helpful for interpreting serology when you do have a syphilis patient. Obesity dosing, some resources around that. I put a picture of a black hole with this because I feel like every time I look into obesity dosing, it consumes a lot of my energy as I'm thinking about what to do with the patient. But there are some nice comprehensive guides that can help you through that and help you make those decisions. So I've included some of those links on the slide. Again, Stanford Guide has a nice section on that as well. For the social media people out there, there's a couple people that I would follow on Twitter or X. A lot of these are either antimicrobial stewardship physicians or pharmacists or ID physicians. And they'll often post like new articles that get published, new guideline updates. So that's another way to kind of just stay up to date with everything that's going on. Oftentimes there's also like good discussion that happens about maybe controversial topics like static versus sidle antibiotics. Does it really matter? So there's good discussion that happens back and forth. So it's a good way just to stay up to date. And often there's just funny content that comes up that I laugh at and can relate to. So before I get to my video, and then we'll get to the Q&A session, Kristin reminded me of a resource that we rely on heavily that I don't have on any of my slides, and it's really the microbiologists. So I would say I probably speak to them on a daily basis. Every time I'm looking at really a culture report where I'm dealing with a more difficult clinical situation, I think it's really helpful to gain their perspective. It helps you understand a little bit about the bacteria. They just give a unique perspective that helps me make a clinical decision. So I encourage you guys to get to know your microbiologists and heavily rely on them as a resource as well. So I'm gonna hopefully wake you guys up a little bit and switch to a quick little 2-minute video, which I find very entertaining. I hope you enjoy it as well. It's very relevant to our topic today. And then we will leave some time for some live questions and answers.
Hi, pharmacy. How's it going? Oh, hi, Dr. Bill. Your medication bottles look very nice and organized today. Thank you. Can I help you with something? Oh, well, I was hoping to order some antibiotics. Oh, of course. What would you like to order? Some meropenem? I'm sorry, I couldn't hear you. What was that? I'd like to order some meropenem, please. Meropenem. Yeah. One of the broadest spectrum antibiotics in existence. Mm-hmm. Have you lost your mind? What do you mean? Do you have culture and sensitivity data to back up this request? Well, it's pending. Have you consulted your antibiogram? I don't have one. Do you even know what you're treating? Yeah, it's a fever. Are you trying to make a superbacteria? Because this is how you make a superbacteria. No, of course not. Hey, Tom. Yeah, what's up? Dr. Bill wants to treat a fever with meropenem. Huh. Is he trying to create a superbacteria? No, I'm not, I swear. Then I suggest you order ceftriaxone and stop trying to destroy the human race. Pharmacy, I got bugs to kill. Infectious disease. What a pleasant surprise. What can I get you? Meropenem. Yes, of course. How much would you like? All of it. Yes, sir, right away. How come he gets meropenem? He, Dr. Bill, is an antibiotic steward. What's a steward? A steward is someone who's devoted their entire career to the responsible use of antibiotics. Well, I can be a steward. Really? Are you willing to go out of your way to shame every other doctor for using broad spectrum antibiotics? Yeah. Are you willing to stop ordering Flagyl for anaerobic coverage? That's what I thought. Better luck next time, kid.
My to-do list used to look like this. A jump.
So I hope you guys enjoyed that video. I thought it was a nice little kind of icebreaker as we start the live question and answer session. I'll stop sharing. Yeah, good call.
All right. I haven't looked at the chat. I think it's. Do we just have the one question from Kelsey? Okay, E. coli bacteremia. Okay, I'm going to read it out because I think it was just sent privately. So, in a patient with E. coli bacteremia, assumed urinary source in a male, history of ESBL urinary tract infections, clinically well. Is this still considered an uncomplicated gram-negative bacteremia? Can we do an antibiotic duration of 7 days? I'm happy to start with that one.
Sure.
Okay. So for a gram-negative bacteremia, as most of you probably know, if it's uncomplicated, usual duration of therapy is now 7 days. Lots of good evidence to say that that duration is fine. So it doesn't matter what the organism is, ESBL or not, that doesn't change the duration that we would recommend. And assuming that there's no complicating factors, so this patient doesn't have prostatitis, they have no abscess anywhere, nothing like that, that's what would make it complicated. If they had kidney stones that were infected, then we need to be extending the duration. So the fact that it's a male doesn't matter. It would still be considered uncomplicated in this scenario, so 7 days would be okay, in my opinion. Anyone else have other thoughts?
I agree.
Great.
I also agree.
Okay, I don't see any other questions in the chat, so feel free. Anyone, unmute yourselves. What is up with all the cavitating pneumonia? Good question. And it's not the winter yet, so I'm sure we'll see more. But there's particular bugs that tend to cause cavitations. So things like Strep pneumo can do it, Staph aureus as well, more likely to cause cavitation. So sometimes you just have more circulation of these bugs in community, like Strep pneumo, for example. So we'll see these waves of people come into the ICU with these kinds of infections. I don't know if anyone else has.
No, I mean, we are actually seeing a lot of strep pneumonias lately, and so we're seeing a little bit more cavitating pneumonias, but yeah, I feel like we're in the midst of a wave right now, so.
Oh yes, there was a question that had come up about Vanco targets, because we're seeing some ID docs, I don't know which ones, tell us and we'll go talk to them, writing these targets of 13 to 20. So that's happening here in Regina? Okay. You know what? I think I might know who that is. I personally don't know of evidence that would say we should be aiming for those targets. Do you guys? Danielle?
No, like.
Sorry, this was a question around Vanco 13 to 20.
Yeah.
Right?
Yeah.
Yeah, I don't think there's any like data to say that 13 to like newer data to say 13 to 20. I guess what I always say is like the 15 to 20 data is like extrapolated from like MRSA data, right? From the AUC to MIC ratio. So, and sometimes when you do the AUC to MIC calculation, there's free calculators online now, you can achieve that AUC to MIC of greater than 400 by achieving a lower target trough. And so I don't know, if I haven't specifically spoken to an ID physician who's written that, if that's why they're writing that or what, but I always have like these soft targets in mind, like 15 to 20 is like 15 to 20-ish. If it's 14 and they're doing well, I don't care, right? If it's 21 and they've got 6 weeks ahead of them, I'm definitely backing off. If they're a few days away from being done, then I'm not, like it's kind of, I always think of them as soft targets.
And I would suspect that the physician writing that also has that in mind. It's probably they're just allowing for a little bit of leeway within there. They're wanting you to target the higher troughs, but they're letting you know that if it's a little bit below 15, they're comfortable with that. But that's probably what that's based off of.
I love Danielle's comments. We worry about Vanco levels so much, you guys. What we have to really do is look at the patient in front of us. Yes, if the level is 14, but the target's 15 to 20, but they've cleared their cultures, they're doing excellent, we're ready to send them home. Don't stress about it. Just leave it where it is. Okay, there's more questions here in the chat. Okay, any thoughts on treating or extending therapy due to high CRPs? Oh boy, this CRP. Anyone? I mean, I have thoughts, but I let you guys go first.
Treating or extending therapy due to high CRPs. So one, I'll say the utility of CRPs when we're using it, it's more so in deep-seated infections, like particularly like osteomyelitis, for example, or maybe like a deep-seated abscess, for example. But where I see it used the most is like septic arthritis, osteomyelitis, deep-seated infections, where we're doing just like a weekly trend to make sure that overall inflammation is coming down. It's not super specific necessarily to infection. So it's an inflammatory marker, right? So you are going to see it elevated in bacterial infections, but there are other things that can also impact that as well too. So when we are trending it, first of all, there's no need for daily CRP trending. I'll just say that we're doing weekly CRP trending to make sure things are headed in the right direction. I mean, certainly if they're starting to trend up, there would be other and if it's related to the bacterial infection, there would likely be other indicators that are showing that the patient is not improving. So if the CRP is trending up, it's probably, I would suspect, not doing so in isolation. And there's probably other things trending up as well. Maybe their white blood cells going up. Maybe they're running low-grade temps. Maybe, their pain is unresolved. Maybe they're not feeling well. And in that case, then yes, I'd be concerned that maybe we're, running into some treatment failure here and maybe need to look at monitoring that regimen. Those would be my comments, thoughts.
Yeah, I think we tend to order CRP a lot in the hospital from what I see anyway, and then people are making decisions solely based on a CRP value when we should be taking the entire clinical picture into account, which is what Mel had said. So for me, the utility is really in monitoring response in these types of infections where we treat for a long time, and it becomes difficult to determine clinically how the person is doing. So if somebody has osteomyelitis, sure, we're making sure that, pain resolves and swelling goes down. But if you're treating for 6 weeks, there might not be anything in those last few weeks other than maybe a CRP to tell you how things are going, because clinically things have resolved. So the utility for me is kind of there, not really with acute infections. Anything else, Danielle?
No, I don't think I have anything to really add. It's, it's a loaded question. There's so many factors to consider. There's utility, but you have to consider the patient as a whole.
Next question, do we ever, oops, no, it went away. Do we ever go more conservative on Vanco targets for an MIC of 0.5 versus an MIC of 1? In other words, 13 versus 15. I don't. Yeah.
And
I don't
think
either. Sorry,
I was just going to add. The echoing. We're echoing here. Sorry. We don't, and that's because too, when you speak to the microbiologists and you get to know them and you ask them these types of questions, they'll say to you that an MIC is never 100% accurate, and so it could actually be, if they're reporting an MIC of 5, it could be 0.5 higher than that, or maybe 0.5 lower than that. So it's kind of within a range. So if they're reporting an MIC of 5, I never take that at absolute face value. There's a little bit of room for error, margin of error, if you will.
Yeah,
so,
it can be off by 1 dilution either way.
yeah.
Yeah.
So we don't change our targets.
Okay, next question. Bacteria in nephrostomy tubes. Do you treat if the patient is asymptomatic? Then my question would be, why did we culture in the first place? Because it's just going to lead us astray. So please don't culture if somebody doesn't actually have clinical signs of an infection. Don't do it just in case to see if something's there. Yeah, it will be there in a nephrostomy tube that has been in place for any amount of time, very similar to a urinary catheter. So if the person is asymptomatic, I would not treat. I would watch closely, tell people what to look out for, when to seek care. Okay, moving along. Unless Danielle wants to add something.
No, I was just gonna say that I agree.
Okay, these are great questions, you guys, and we're fine to stay a little bit late. We understand if anybody needs to leave, but we're happy to answer. So next question was, how can pharmacy be involved if we never actually see the wound? In other words, a lot we need to, AKA, I'm not sure.
This is
exactly.
probably a vascular problem, is my guess.
Okay.
Basing that it's coming from St. Paul's. Yeah, I don't know. Like, I don't have a ton to say on this. Like, wounds are hard. They are one of my least favorite areas of stewardship as well, because I also find even if I could go see the wound, I'm personally not trained at this point in my life to say whether that wound is infected or not. I mean, there's certain questions I think you could ask around it, around like fluctuance of like purulent material, and that sort of thing, that might prompt then the physician to consider whether it's actually infected or not. But I do agree, and I don't know that I have a ton of guidance at this point around wounds, but I don't know, Kristin and Mel, if you have more experience with stewardship in wounds or not, but.
I would also just add that, yeah, I would not feel comfortable assessing a wound. Usually when we go in there, it's with the physician and they're making their assessments, and I'll watch and observe so that I have an idea of what they're referring to. But I think one thing that I've found helpful, if I'm working up a patient for the ID physician and it is a wound, even if I haven't gone and physically saw it, wound ostomy, at least in our facilities, leave really good notes on SCM. And so I'll often refer to those notes, and I'll just kind of look to see if they're mentioning that things are improving, and look to see how they're describing it, if there's purulent discharge or if it's just serosang, or what their descriptions of the wound are, and then I'll report that back to the physician, and then it'll be a conversation on what to do moving forward.
So in addition to those things, I guess I would just add, in general, I'm not sure, the specific issue, but things can look really bad. Wounds can look really nasty and not actually be infected. Okay, so there's a lot that goes into this. If people don't have proper blood flow, if they're diabetic, things can look really nasty. But if you don't have like purulent discharge, and if there's active scabbing and things are looking pretty good, it also depends a little bit on the bug that's causing it. Like group A strep will make things look really like hot and red, and it will stay that way for some time, where other bugs won't necessarily do that. So, and then there's a lot of differences between disciplines. So I've gone in before and nurses have told me, oh, this wound looks so terrible. It's so infected. They need antibiotics so bad. And then I go in and I'm like, oh, no, I don't think so. Completely different kind of assessment. And so, yeah, it's not so easy. And if you're not seeing it yourself, you can ask some of these questions, is purulence present and all those kinds of things to get a bit of an idea. But yeah, there's no great answer to that of how you can approach it necessarily. Not sure if that's helpful. Next question was cefazolin MIC with a note of it being based on uncomplicated UTI. Can you confer susceptibility if the organism was not found in the blood? Great question. So there are different breakpoints for some antibiotics depending on where you isolate that bug from. So breakpoints in the blood so specifically for gram negatives, the enterobacterales, the breakpoints in the blood will be different than the breakpoints in the urine. This is because antibiotics concentrate very highly in the urine. You don't need as much present necessarily systemically in order to kill that bacteria in the urine where you would in the blood. So the breakpoint is different. So this specific one, yeah,
But I think are we asking if it like
I had
like
a
I guess
typo.
I oh okay. Do you want to clarify?
Yeah, it was essentially like an organism grown in the blood, but then it confers that it's like for an uncomplicated UTI. But if you're not thinking the source is from the urinary tract, are you able to confer susceptibility? Or would you want to like phone micro or like check different breakpoints?
So if you have breakpoints from the urine, you cannot confer those to the blood because the breakpoints would differ.
Yeah, I'm just sometimes I
So-
wonder why it's listed as that when it's a blood culture.
I'm trying to think. So you think you've seen like cephazin susceptibility in a blood culture with the note about it's only applicable for lower urinary tract?
Yes.
Oh, that's interesting. Maybe send that to me next time you see that, or if you can recall the patient, because I'm having trouble envisioning that.
Okay, thank you. Yeah, I don't know when it happens, so if I see it again, I'll send it your way.
Great question. And yeah, so what Danielle was saying, you can't confer susceptibility from the urine to the blood, but you could go the other way, from the blood to the urine. But this sounds like a different issue of just how it's reported out. 5 people if you need to leave, no problem. Okay, Kat's question, does procalcitonin have a role outside of the ICU? I've heard you talk about it before, but it's not even available in your hospital. Mel's the Procal girl.
Okay, I think this will be our last question because we're getting punted from the room. And thank you for everyone's questions, by the way, and the interaction. So procalcitonin, there is a role for it outside of the ICU. There's evidence for it in Emerge. There's evidence for it in pediatrics. I'm sure there's evidence for it lots of places. I think what we've found is that if you are going to use it, it is best to have some sort of criteria with how it's being used, because people can use this and it just ends up, they use it and then they don't act on it. And so then it just ends up being another cost to the system. And so the recommendation is, at least from our experience and what I've been reading, is if you're going to implement this within your facility, that there be some sort of standardized protocol with how to use this so that physicians can know when to order it and know when to act on it. And then that way you can encourage them to act on it when you have those values. And then it's more likely to be successful and to actually guide your clinical therapy. If you just let it wild,
Like CRP.
it becomes, and D-dimers, they just become a test that gets ordered all the time and doesn't really guide clinical decision making. So
yeah, or it's being misinterpreted.
Or it's being
not used
misinterpreted.
correctly, so
yeah. So good questions. Thank you guys very much for your interactions. Hopefully we answered most of your questions. Have a good rest of your afternoon.
And if you guys could just fill out the poll everywhere with any of your feedback, that would be great. And thanks so much for the presentation, you guys.